high-risk myeloma is a subtype of myeloma. So when we speak about myeloma, we do know that the disease is very different in each patient. That means that the disease can behave very differently, especially in terms of aggressiveness. How quickly does the disease respond, but also how quickly does it potentially relapse again after treatment. High-risk myeloma is a group that we cannot really just identify only through looking at the patient, not even to just looking at the cells under the microscope, but we need genetic tools to really capture all the patients correctly. So we do use genetic analysis methods now that include methods that are around for longer already, such as FISH testing, or newer methods such as next-generation sequencing. But we also have found out through our research that gene expression profiling, which is looking at a different type of genetic analysis, adds more information and helps us identify patients with high risk really precisely. The new classification of high-risk myeloma by the International Myeloma Society and the International Myeloma Working Group is taking really a thorough view at all of the evidence that has been emerging over the last years. And it is based on a genetic analysis that includes more tests than what we've had so far. So the analysis looks at mostly changes of the genome, mostly larger changes of the chromosomes. These can be translocations or copy number changes, as we call them. But the new thing that it also includes, in contrast to before, is a genome mutation of a gene called TP53, which is one of the commonest tumor genes that we find across many different diseases. And that way also opens up that myeloma can be analyzed by newer methods of genomic analysis. So effectively, it brings us to the modern age about doing more genetic testing in myeloma than we were doing before. But it also opens up the opportunity of using new methods for the genomic analysis that we haven't been using before. The impact of the new classification system in clinical practice is that we have a more precise way of defining and identifying patients with high-risk myeloma than we did have before. I think one of the most important changes are probably not directly visible to the patient. It just means that in the laboratory, we now have an international consensus that we should do more testing and that we should do more precise testing for every patient. And that's, of course, a very important really improvement to before. I think myeloma has been a little bit behind a lot of other hematological blood cancers in terms of the genetic testing, and that's getting much better now. I think it also allows us really to identify more of the patients that really have a high unmet need, that really need new treatment approaches better than before. It will, over time, of course, allow us as well to run specific trials for this high-risk population in a more focused way than we have been doing before. There are several prospective trials now for high-risk myeloma patients. Most of them at the moment have been focusing on patients that are younger and fitter and can tolerate treatment a bit better, because the treatment at the moment that we can offer for these patients means more intensity of the treatment or longer treatment. But actually, we're going to present here now a long-term follow-up of the high-risk trial that we have, for example, run in the UK. That is now where every patient has been on treatment for 6 years or longer now. And that's very important to know. We often see results of early results from clinical trials that are just used after 1 or 2 years that show very good results. And then when we see further follow-up after another 2 or 3 years, we see, unfortunately, that many of the high-risk patients at that point relapse. Now, this new trial, the Optimum or MAC9 trial, has actually compared against historical comparator and shown that we can really substantially improve the outcome of these patients. They stay in a remission for much longer, and even after 6 years, more than half of the patients are staying still in a response. But most importantly, we can even show in the trial with 6 years follow-up that more patients are surviving. We have actually added this up, and we have come to the conclusion in a country that is as size of England, that over a time frame of 6 years, there can be probably 100 patient years, over 100 patient years saved by using a treatment for high-risk myeloma that's specific for these patients. The problem at the moment is that one needs access to this treatment, and I think that is one of the biggest challenges that we now face as a community, and I'm sure we're going to make progress together as patient organizations and physician organizations in getting better access. I think what the high-risk trials have shown is that we are clearly improving the outcome of patients with high-risk myeloma. One of the challenges that we're facing is that these trials were run as we call them academic trials. So actually they were not directly run by industry partners, pharmaceutical industry partners. And that brings a slight challenge as to how our healthcare systems are picking them up. We have actually very well established pathways whereby a pharmaceutical company can bring a new treatment to a country, and the country will decide in the European system, often on the basis of effect size, whether it wants to reimburse this. Actually, the data that we see emerging from the high-risk trial is probably better than many of the data that we see from industry trials. The problem is that we don't have a unified system how we get such a treatment reimbursed. So I think it's really a new frontier, and it's something that we should all see as a big opportunity to make together an effort as a physician and a patient representation community to speak with our healthcare systems, because the actual absolute difference in terms of costs should be not so high for the systems. It's more about the way, how do you get the treatment approved?